Welcome to AETCM, the Emergency Medicine Channel.
Yes.
Presenting a 73-year-old female, known case of hypertension and hypothyroidism since 10 years. She came with complaints of abdominal pain since 3 days, loose stools and vomiting since 4 days. Her abdominal pain was dull aching in nature, intermittent, diffuse, and no aggravating or relieving factors. She also had a history of loose stools.
First of all, you tell where is the abdominal pain? We have 9 quadrants. At least tell upper middle, upper left, upper lateral, like that. Something you tell so that it is initially itself it is taken care.
Okay. She was having predominantly upper
right side.
Yes. Along with that, she had a history of loose stools and vomiting since 4 days. Loose stools was watery in consistency. There was no blood in stools or mucus.
Blood indicates what? Blood in stools indicates what?
Fresh blood. No, blood in stools could be dysentery.
Dysentery. Blood in stools is dysentery. They are all dangerous bacteria.
There was no history of fever and no history of food intake from outside. Her vitals on arrival: heart rate was 68, BP of 150/80, a respiratory rate of 20, temperature of 98.5, saturation was 98% at room air. Systemic examination: abdomen was soft, there was tenderness in the epigastric and right hypochondrial regions, no organomegaly or free fluid was present.
So, pulse, BP, everything is normal?
Yes, sir.
Everything is, vitals are normal?
Normal, yes.
There is no hypotension,
No.
nothing, but only thing is abdominal examination.
Tenderness was there. Her routine labs: CRP was 151, WBC was 11.1, hemoglobin of 10.2, platelet of 1,65,000, creatinine was 1.9. Along with that, her AST was 110, ALT was 92. And yes, so that was the initial routine labs. Her blood cultures were also sent. So, suspecting a probable enteric fever, we had started her on ceftriaxone 2 gram OD.
How do you suspect enteric fever clinically? What are the clinical parameters which tell you that this may be enteric fever? That gives a clue.
One
so
is
all fever
symptoms.
cannot be enteric fever, no?
Yes.
So after diagnosing it, it is very easy to tell that it is enteric fever. But when a patient you are seeing first time, how do you think that it is a probable enteric fever?
Relative bradycardia maybe.
Okay, one is diarrhea. Okay, diarrhea is very common in enteric fever, especially what type of typhoid? Typhoid or paratyphoid?
Typhoid.
Paratyphoid. So diarrhea is very common in paratyphoid. Typhoid also can have some amount of diarrhea, but it is severe in paratyphoid infection. Then next is
rose
pulse.
spots.
Rose spots are seen in typhoid. Okay. Pulse.
A relative bradycardia.
What is the relative bradycardia?
At the peak of fever, the pulse will be, there will be bradycardia at the peak of fever. I mean, like...
for every 1 degree rise in temperature.
So it is very important. It is not actual bradycardia.
Yes,
it is only a relative bradycardia. For every degree rise in temperature, you need to have extra 10 beats. That response will not be there. That is relative bradycardia. But where all you get relative bradycardia? What are the other conditions you are going to get?
Viral infection.
Viral infection. Okay, dengue fever sometimes you can get.
Brucella.
Brucellosis you can get. What is a common scenario? Common scenario is what? Beta blockers. Patients nowadays, many patients are beta blockers or rate limiting calcium channel blockers. And in that patient, if they develop a fever, you don't get like tachycardia. So that is nowadays that is a common cause for relative bradycardia. But if you are taking infectious disease, brucellosis, dengue fever, enteric fever, all these things you can have a relative bradycardia. There are some viral fevers that can develop myocardial involvement. Okay, that can sometimes produce tachycardia or bradycardia. If the conduction system is affected, then it can produce bradycardia. Okay.
Yes. So
Jaundice produce bradycardia or tachycardia? Obstructive jaundice produce bradycardia.
Yes. So for this patient, we had started on ceftriaxone 2 gram OD. Her blood culture within one day showed growth of Salmonella typhi. But after 2 days, she still continued to have continuous abdominal pain. We had sent amylase lipase. Her lipase was 829 and amylase was 318.
Which is more specific, amylase or
Lipase. Lipases.
Why amylase is not specific?
It's also produced by the salivary
Saliva, intestine, bones, so many things can produce amylase. So it is not a specific investigation for pancreatitis. Lipase is more specific.
So both were elevated. Her USG taken on the first day of admission did not show any features of pancreatitis or any peripancreatic collection. Her MRI was done on the fourth day of admission, which was showing a bulky tail of pancreas with pancreatic fat stranding, which was suggestive of pancreatitis. So she was started on aggressive fluid resuscitation, and within 2 days there was an improvement.
Tell me about diet restriction in pancreatitis.
Yes,
It's an infectious pancreatitis, mostly because of enteric fever.
So initially, patient was kept NPO to prevent pancreatic enzyme stimulation. Within 2 or 3 days, we can slowly start on soft diet.
If it is a mild pancreatitis, you can continue the feeding without fat feeding. So moderate, you can even start the feeding by after 24 to 48 hours. It is severe only, we have to restrict the feeding, especially fatty food. Okay. So feeding, early feeding or late feeding is good in ICU.
Early feeding.
Early feeding. So previously it was told that you have to keep the patient in NPO in ICU for intubation or so many things. But nowadays we know that early feeding is always better than late feeding in ICU, because that is going to improve your intestinal flora and lot of other things, immune mechanism. So better to start the feeding as fast as possible.
Yes. So we had kept her NPO for 1 day, and she was able to tolerate soft diet after that.
I understood. What else? What all things you have to look in a patient with enteric fever, pancreatitis? Other than your antibiotics, you are given, rightly you are given ceftriaxone. That may be sufficient. Should we give any ICIN antibiotic in pancreatitis?
No, there's no indication unless there's infected.
Infection is done. This is enteric fever.
No, it's like infected pseudocyst or
Necrotizing pancreatitis.
with infection.
So if it is not something other than enteric fever, you'll have to hike to imipenem, cilastatin or meropenem. Otherwise, enteric fever, this will be enough, more than enough, unless until you prove it by your culture that is a different organism. Otherwise, this is okay. So that antibiotics you are given, NPO you have kept. Then what else to be done?
Aggressive fluid resuscitation.
So fluid has to be given. Why fluid? How do you know that patient is having fluid deficit? How do you understand that patient has lost fluid to third space? That is the most important thing. So how do you know that? IVC can be checked. IVC collapsibility can be checked. Then input or urine output is very important finding. Then hemoglobin and hematocrit. So that is a thing you will see in pancreatitis with fluid loss. Hemoglobin will be slightly higher, hematocrit will be higher, and like they told, IVC collapsibility, then urine output, lactate levels. All these things will tell you whether the patient is having adequate internal perfusion because of fluid in the IVC, in the vascular compartment or not. Then what happened to the total count?
Total count was 11,100.
What happens in total count in typhoid?
Can be leukopenia also.
So most of the time it will be normal or slightly lower. Okay. This is the one bacterial infection where the counts are not really elevated. Okay. What happened to the CRP?
151, so it was higher side.
It is higher. So what does it indicate? Is it mild, moderate, severe pancreatitis?
Moderate, so that.
More than 150 is a severe type of pancreatitis. It's very high. Okay. But alone with that, you cannot tell it is. The other features you have to see. Then, so there is a scoring system for that. In that, everything will come: B1, creatinine, CRP.
Yes.
What is the calcium level here? Is it important?
Yes. In pancreatitis, hypercalcemia can also be a cause of pancreatitis.
Hypercalcemia can produce pancreatitis.
Pancreatitis can produce hypocalcemia.
So both are possible. Okay. What are the reasons for pancreatitis? Why this patient may be because of enteric fever? What are the common reasons for pancreatitis?
Most common is gallstones.
Gallstones.
Then alcohol related.
Alcohol.
Structural anomalies like pancreatic division, diverticulum.
Okay.
Then certain drugs also can cause.
What are the drugs?
ASA can cause 6-mercaptopurine. Then azathioprine.
Okay. Okay.
Then other.
Tenofovir, tricitabine, lamivudine. You told azathioprine. Okay.
Then cystic fibrosis, autoimmune.
What is the difference
Infections.
between alcoholic pancreatitis and infectious pancreatitis? These are the two common things which is seen in our country. Gallbladder stones also will be there. That is an acute problem. Difference between alcoholic pancreatitis and infectious. That is the main difference. Alcohol is slightly slower onset, whereas infectious is sudden onset. Even gallstones also sudden onset.
These are the most common causes. The grading systems that are used, one is Ranson's criteria, which evaluates at 0 hours and 48 hours. So there's 1 point given for each thing. So age more than 55 years, WBC count of more than 16,000, GRBS of more than 200, LDH of more than 350, AST of more than 200. This is at 0 hours. At 48 hours, hematocrit fall of more than 10%, a BUN increase of more than 5, calcium of less than 8, partial pressure of oxygen of less than 60, base deficit of greater than 4, or fluid sequestration of more than 6,000 ml.
Okay.
Then the other criteria that can be used is the BISAP scoring, where B stands for a BUN of more than 25, I is impaired mental status, S stands for features of systemic inflammatory response, which itself has criteria. That is
it QSOFA criteria?
Used in sepsis.
Here also, everywhere it is same. Okay, ICU, it is used in ICU.
Consists of systemic BP, mental status, and respiratory rate. BP of less than 100, systolic BP of less than 100, respiratory rate more than 24, and impaired GCs, impaired mental status.
Depending on the score?
Score.
Okay.
Grading.
If there is no sepsis, you get a patient who is having hyperventilation syndrome here in emergency room. If you see QSOFA, everything will be positive. Altered behavior,
Yeah.
tachypnea, tachycardia. And what is the third one?
Systolic.
Systolic BP. Normally it will be, most of the patients it will be low. So this is alone is not a diagnostic criteria at all. When you have a sepsis patient or something like this, you try to prognosticate the disease, you can use it. So alone this one will not help you to make any diagnosis.
Then part of the BISAP, age more than 60, P is pleural effusion. So greater
Which
than
side pleural effusion? Right or left?
left side.
Left side.
More than 3 indicates higher mortality. Then there's also the Balthasar CT severity grade. So
Severity index.
So in that, grade A, which is 0, is a normal pancreas. That is, there is no enlargement or peripancreatic inflammation. B, which has a point of 1, there's this focal or diffuse enlargement of the pancreas, but there's no peripancreatic inflammation. Grade C, there's peripancreatic inflammation with intrinsic abnormalities of the pancreas. Grade D, there is intra and extra pancreatic fluid collection. And grade E, there is 2 or more large collections of gas in the pancreas. So according to that, the points given, if the points are 0, then there is 0% of necrosis. If grade is 2, then there is less than 33% of necrosis. If the points are 4, 33 to 50% of pancreatic necrosis. Grade 6, more than 50% of pancreatic necrosis.
Okay. Gas in the abdomen, that is a specific topic. Gas in abdomen. Wherever there is an infection, if you are seeing gas, what will you suspect? What is the first suspicion will come to your mind?
Perforation.
That is when it goes out, gas will go out. But in an infectious area, if you are seeing gas, kidney, gallbladder, pancreas,
Anaerobic.
anaerobes, gas forming organism. So you may have to add an anaerobic coverage to your existing antibiotic, like metronidazole or something you have to add. But that doesn't mean that all gas containing infections are due to gas forming organism. But when you see clinically like that, better to add drug
Anaerobic.
like below diaphragm metronidazole and above diaphragm it is
Clindamycin.
clindamycin. What it told? Clindamycin.
Yes, sir. Then there's the classifications of pancreatitis. The revised Atlanta classification has two: interstitial acute pancreatitis and necrotizing acute pancreatitis. WHO classification has one acute pancreatic collection, pancreatic pseudocyst, acute necrotic collection, and walled-off necrosis. So,
So, do you manage this enteric fever then afterwards? How did you manage?
this patient, we started on antibiotics, ceftriaxone. We had also added azithromycin, 1 gram OD.
What is the indication for azithromycin?
This thing in case of like resistance, but in this, yes.
Azithromycin.
Azithromycin
You can add to the regimen.
Salmonella, right?
Okay.
In the regimen. Antibiotics we had started, just fluid resuscitation. So within, we had given this for 10 days as IP,
Okay.
and we had discharged, otherwise her symptoms had reduced and we had discharged her.
Okay. Suppose the patient develops altered behavior. This patient has developed complications of enteric fever. He may develop enteric encephalopathy also. What will be the clinical finding? How do you treat?
CNS manifestations,
Of typhoid.
yes, it can cause meningitis, can
Cause meningitis, encephalitis, cranial nerve involvement, everything, transverse myelitis. What is the peculiar nature of that disease? Enteric encephalopathy. Every encephalopathy you get now. Picking up the imaginary things from the bed sheet. That is a sign of enteric encephalopathy. Okay, symptom or sign? It's a sign. No, you are picking up something. That's a sign of enteric encephalopathy. Okay,
Yes.
how do you treat it? Enteric encephalopathy. How do you treat? You had a patient last week. Steroids. What is the dose of steroids? High dose steroids. So,
Pulse level.
it is something like pulse steroid you give, no? That type of steroid treatment is required. Dose is very high. What steroid is useful? Which type of steroid is useful? Dexamethasone. Due to? What is the reason? Reason for dexamethasone?
better CNS penetration.
Better CNS penetration. So, dexamethasone high dose is the treatment for enteric encephalopathy. But the only problem is when the patient is having enteric perforations, enteric fever induced perforation. This can sometimes be dangerous also. Okay, that we have to keep in mind. Otherwise, that is a treatment of choice, enteric encephalopathy. What are the other organs involved in enteric fever?
It can cause arthritis, osteomyelitis. It can affect the heart, causing myocarditis, endocarditis. It can cause pneumonia.
So every organ
can
in the
be
body
affected.
can be involved by enteric fever. We are not seeing nowadays because we start some antibiotic. If we start like azithromycin, augmentin, whatever, small antibiotic, the disease will be controlled. But if it is a resistant, again it will come back. That's all. Okay, tell me something about carrier state.
Chronic carrier state, such individuals are usually asymptomatic, but they continue to shed the bacteria in stools for more than 1 year. So they can be a source of infection to other
So
individuals.
whom will you
also.
test it? Which type of patient?
Especially people in the food industry.
So if they are in the food industry, always you have to check the stools after some time and see that there is no culture positivity in stool. If it is positive, then what you do? Which
Chronic carrier state,
what is the antibiotic?
for eradication, fluoroquinolones.
Quinolones are better drugs. Why it is like that? What is the reason?
Gallbladder
So
penetration.
gallbladder, it is excreted out through gallbladder. So the concentration of quinolones are very
By-
high in the gallbladder. That's why we are giving quinolones. There also we have to see whether it is resistant or not. Okay. So what happened to this patient finally?
So this patient, we had given 10 days of antibiotics. She was discharged after that. So, but she didn't come for follow-up after that.
Okay.
But yeah, so no other further
There
symptoms.
is no
were
other issue. Anything else you want to add? Nothing.